Medication Administration, Part 2. This is Martha Olson from Iowa Lakes Community College. As we look at medication administration, we have to think about passing medications, and if the client says, this isn't the med I take, what steps will you take to make sure that you are indeed passing the right medications? If the patient says, I take this med at bedtime and it's in the morning, what are the things that you can do in that case? And then as we think about the timing of medications, oftentimes the physician will not write the time for the meds. You have to know the meds, what they're for, what they're indicated for, and set them up for the right time that they need to be given. The right documentation. We scan with the MAR. It uploads onto that, and then we have to document. If you do not give the medication for some reason, the patient refuses it, the patient is down to X-ray and their NPO, there is a button on there that says non-administration reason, and you have to select the best one for why the medication wasn't given. Never document a med until you've actually given it, because perhaps there's a reason why the med won't be given, and you would not want to chart that in error. When we think about the drug class, we also have to think about other things that have to be documented along with that medication. Many of the computers are set up to prompt you into looking at that, and you get very used to thinking, I need to check my INR before I go in and scan my warfarin or Coumadin, because it's going to prompt me, and I can't give that medication unless I know the answer to that. And that's because if your INR was too high, you would not want to give that. And it's your double check, it's your red flag that there's a lab value that is closely related to giving that medication. Same with your antihypertensive medications. Many times they will ask you right in there when you're charting on your MAR, what is your blood pressure? Your cardiac glycosides, it's slow and strengthen the heart. It will ask you for your apical pulse for a full minute. What's the number? And if it's less than 60, we know we need to hold that. Insulin, obviously, it wants you to prompt with a blood sugar, because you would not want to give any insulin if you had a low blood sugar, because it's going to make your patient even more hypoglycemic. We need to know the drug classification. You know, what class is this med from, and what's the usual dose? Because if it's not the usual dose, why are we giving something much higher or lower than what is indicated? The side effects, what are precautions, some of the reasons we wouldn't give it a contraindication, and then the nursing interventions need to be taken with food, needs to be taken on an empty stomach, IV push slowly over 2 to 5 minutes. All of those things you have to know before you can administer any medication to know that you are doing it safely. The triple check is when you take that med out of the Pyxis, out of that MAR, and you look at the MAR and you look at the unit dose wrapper to make sure you have the right med. You also do the second check then when you're putting it in the med cup, and then when the med cup, and you match it up a third time when it's in the med cup, and you get that third one done to be sure that you do indeed have the right medication. Our administration times oftentimes are written as an abbreviation. Before meals is AC, after meals is PC, bedtime is HS, hourly is H or HR. We are trying to get away from using abbreviations, but you still may see some of these, so I post them here for you just so that if you get into a clinical situation and you see those, you will indeed know what they are. But as I said, it's best not to use abbreviations, because it's another reason we can see med errors. Factors that affect the potential response, you know, medication history. And this is a slide I would spend a little time and look at and think about how is she going to put that into test questions. Things that put them at risk are problems with perfusion and oxygenation. Perhaps they're on a lot of meds because they're a diabetic, and so the meds are interacting and they don't have good blood flow, or they're dehydrated. Allergies, coordination and perceptual problems can affect their response to medications. What's their current condition? Are they very hypovolemic? Have they just hemorrhaged and they're very low in blood volume and blood pressure? Knowledge and understanding. You know, if they understand that they need to take it on time, and if they miss a dose, not to double up on the second one, is very important for how the person's going to respond. If they don't take their medications on schedule and as they're supposed to, it can have a whole lot of negative effects for that person, because the body is not getting the medications at the time and dose that it needs. And then what are their learning needs? Do they understand how to take the medications correctly? So when we think about one of the first bullets in that last slide, we think about history that might put them at risk. You're diabetic, people with liver and kidney failure, huge risk for having problems with their medications, because the liver, remember, metabolizes and the kidneys eliminate the medication. And so if you're not able to break down and metabolize and eliminate, that medication is going to stay in the body and become very toxic. A person with an organ transplant, they're going to take the anti-rejection medications. They're going to be very immunocompromised. Your patient with cancer, any of those types of history can complicate the medication response for your patient. When we look at factors affecting potential response, what's their current condition? Absorption, we think about, can they swallow? Can they keep it down, or are they going to vomit it back up? A person with history of maybe gastric bypass, where they've had their stomach stapled to lose weight, or Crohn's disease, where they've lost a lot of their small intestine because of the disease process, might have problems with absorption. Metabolism, we typically think of the liver, but we also need to think about the blood volume and the blood and the processing of that, getting that medication from the small intestine to the liver, and then can it be broken down once it's in the liver? The hepatocytes, or the cells of the liver, are they healthy, or is this an alcoholic that maybe has a lot of liver damage? Blood flow into and out of that liver, their hydration status, many things can affect metabolism, as well as the elimination. Can the kidneys eliminate that medication? Is there good blood flow into those nephrons to spin and to cause the filtration process? Are they well hydrated so that they have urine elimination, or is the antidiuretic hormone kicking in and saving all of that fluid because they're very low in their body fluids and blood volume? And then other medications that they're taking might influence or affect their ability to eliminate. Factors affecting potential response as far as labs. When we think about your BUN and creatinine, the kidneys, are they able to eliminate? Your AST and ALT are the lab tests that go with liver. Is this a healthy liver? So when we look at lab values, they very closely relate to our medication administration. Hemoglobin and hematocrit is your blood volume. Can you carry oxygen to the tissues? Are you getting good response at the tissue level to oxygenation, or are they hypoxic? And then albumin is a key part of that. Remember, albumin is a protein. It has to do with binding of the proteins and getting them to where they need to go within the body. And so a person that has a low albumin or pre-albumin level can have some side effects with the metabolism and administration of medications. When we look at the order of giving medications, we can't just think we're going to scan our meds and just give them all the medications at the same time. There are rules about the order of medications and how we give them, and it matters because some meds have to be given on an empty stomach. There are meds that are given at 8 a.m. because they have to be given with food because they're very GI irritating. Some of the meds we know that have to be given last. Your cough syrup and your nystatin, which is a swish and swallow for thrush, that's always given last because you want it to coat the throat, coat the back of the mouth, and you don't want to chase it or have any water after it because then the medication won't work. We think of giving the smallest pill first because then I can assess how they swallow. If I'm not sure how this patient is going to swallow, maybe they've had a stroke or they've had some difficulty, I give them the smallest pill first because their chance of choking on that is a lot less, and I can evaluate how they're going to do. If they kind of have trouble with that very small pill, I might go and crush the other pills and put them in applesauce if they're able to swallow, in applesauce better. So there are rules of the medications. When we give the respiratory medications, we think of giving the bronchodilators first because then the corticosteroids that come second are able to get into the deeper airways to be effective and to work. So when we look at these medications, the ones listed on the left side, your potassium, you give a breathing treatment of albuterol, which is a bronchodilator. Your nystatin for swish and swallow for a patient with thrush. They get eye drops for glaucoma, and they also get a topical nitroglycerin patch. Your order of medications obviously is going to be giving the breathing treatment first so that they are supporting and taking care of that airway first. Then you probably would give the oral potassium, the swish and swallow nystatin after that without a drink of water. Then you can give the eye drops and put the patch on. On the right hand side you have an antiemetic for nausea and vomiting. That's probably going to be given first and wait a while so that when you go in and give the vitamin they're able to tolerate it, because we know vitamins are very caustic to the stomach and be very GI irritating. And then obviously your cough syrup is last because we don't want to drink water after that, so it can have the effect at once. So again, your albuterol is first for opening the airway, and in the second set, remember your cough syrup is going to be last because we want it to coat the throat and be able to work. Math review is going to be on your own. If you need help, the Resource Center is open. You'll want to review metric, household measurements in the apothecary system. A couple of Miranda rules to remember: never have that trailing zero, because if I write 5.0, it could be misconstrued as 50. Always include a zero before a decimal point so that it's understood, or you can see very clearly that there is a decimal point. Otherwise that decimal point might be missed. So when we think about, is a medication in the therapeutic range, we oftentimes have to take the weight from pounds to kilograms, although many hospitals now are obtaining weights in kilograms to make it much easier for the conversion of medication from milligram to kilogram for our doses. So if we have 500 milligrams ordered BID, or twice a day, the therapeutic level is 1200 milligrams daily, the answer is no. That dose is too low and it's not therapeutic or going to keep that person well. Medication errors happen for a variety of reasons. We know that it is a process and it is not any one person's total error. It's a systems error. And when we look at the nurse that administers that medication, we're the ones that have to know that it's been done safely up and to the point and at our position of giving the med, because we're liable. If the physician orders something incorrectly, we need to catch it. We need to call the physician and say, is this correct? Is this really what you want given? If I don't agree with the medication, if I don't think it's safe, I'm not going to give it. I'm going to be talking to a supervisor or somebody to get some clarification. If it's not written or transcribed correctly, if the pharmacist dispenses it incorrectly, and if I administer it incorrectly, these are all areas of potential medication errors. So we know med errors happen for a variety of reasons. Polypharmacy is one. You can see all the pills in that lady's hand. Do we always know every med that the patient is taking? Is there an error from the nursing home to the hospital where we do the med reconciliation? We get tired. We can scan the wrong med. We don't follow the processes of scanning and not doing everything like we should. And so med errors still do happen. When they cause harm, we have to think of what we need to do for that patient. And our med errors happen most often when a client is transferred from one facility to another, from the nursing home to the hospital or back, when the nurse is distracted, when we've worked 3 12-hour shifts in a row, when we're just very tired and very fatigued and gotten kind of in a negative routine. This is Objective 159, looking at the role of the RN when we have errors and when errors do happen. And we have to think about what is the role of that conscientious nurse when a med error happens. One of the things we need to think of is, don't hide the error or cover it up. It's very easy sometimes to think, oh, George got the pills that were not intended for him, but oh, it was just a medication that won't cause any problems. I won't say anything. Or pretend it didn't happen because we are afraid of getting in trouble. When we fill out the incident report and we make it known that an error happened, that's when the systems can be changed, and that was one of the reasons these very expensive Pyxis systems were purchased, because they have been known to help decrease medication errors. We learn from our mistakes, and when we identify them in an incident report, then the whole system can be changed to help make some improvements. So as we move on to part 3, we will be talking about some of the abbreviations that go with errors. Thank you.